Hi everyone, and welcome to this podcast, which is on how NHS Gloucestershire ICS is using digital to enable system flow and help alleviate winter pressures. So this podcast is part of the Digital ICS programme, which is a free support offer for integrated care boards and integrated care system leaders. It is delivered by NHS Providers in partnership with the NHS Confederation and Public Digital, which is my organisation. We're a digital transformation consultancy based in London, and I lead the healthcare practice there. The Digital ICS programme is an extension of work we've been doing with NHS Trusts over the last few years, and it's all designed to build board understanding of the potential and the implications of the digital agenda at system level, and to support ICS leaders to harness the digital opportunity. So we had a great discussion with members of the Gloucestershire ICB. We spoke to Ellen Rule, Deputy Chief Executive Officer and Director of Strategy and Transformation, Eve Ollivant, who's Director of System Flow, and Dr. Paul Atkinson, who's the CCIO and Digital Lead there. I hope you enjoy it. Please refer to the NHS Providers website for more detail on the programme offer, and hopefully see you in a board session soon. Thank you. Welcome everybody, and thank you very much for joining. I'm hugely excited to have this conversation today, and we are going to be talking about a digital approach to improving system flow. I'm excited really for two reasons. One, because, heading into winter, with many trusts under significant operational pressures, and lots of systems wondering how they're going to be able to manage, this is a really, really timely discussion. So I think there's a real kind of, if you like, tactical benefit for those people listening. I'm also fascinated from a more strategic perspective in the kind of ongoing enigma of NHS productivity and the kind of ongoing political debate around this, and the role that flow is thought to play in that productivity puzzle. So really important topic. I'm sure it'll be a fantastic conversation. I'm delighted to be joined by three members of the Gloucestershire Integrated Care Board. And before we get into the discussion, I'd be delighted if you could introduce yourselves. So perhaps if we could go in the order Ellen, Eve and Paul. And Ellen, I will hand to you first to introduce yourself.
Thanks, Chris. So my name is Ellen Rule, and I am Deputy CEO and Director of Strategy and Transformation of the Gloucestershire Integrated Care Board. And I have quite a wide portfolio of responsibilities, but one of those is working with my team on UEC, transformation and system flow.
I'm Eve Ollivant. I'm the Director of System Flow for NHS Gloucestershire.
Good afternoon, everyone. So I'm Paul Atkinson. I'm the Chief Clinical Information Officer for the ICB, and I lead the digital team.
Wonderful. Thank you very much, and welcome all. And I want to start with perhaps an unusual question, but just in case there are uninitiated listeners out there, what is systems flow? And I'm going to come to you for that, Eve. So yeah, over to you, Eve.
Yeah, thanks, Chris. Not a difficult question at all, really, in terms of uninitiated. I think it's a flow that's a term that's broadly used to describe so many different things, but in its simplest terms, it's essentially the way that the patients and public access our health and social care services. So that can be at any point. So that could be from the point of a patient picking up the phone because they feel unwell and dialing 999. That could be them attending their GP surgery. Or that could be a patient moving from a hospital setting into a community hospital setting. In its simplest terms, again, I think you have either got elective planned care into flow, which is a much easier thing to manage. So if you go to your doctor and you need to have an operation or to see a specialist appointment, but then there's obviously contact with health and social care services in an unplanned way, and that definitely currently at the time is the most difficult thing to manage, I think, in terms of managing people's flow and their journey through multiple sets of services with the highest quality of care provision and treatment, and also in a timely way.
Really helpful, thank you. And I mean, thinking about Gloucestershire then, let's start with the kind of the outcomes. Like, what was the problem that you were observing there that you were trying to solve?
I came into post as Director of System Flow just over 2 years ago. I'm a nurse by background. I'd worked in the Acute Hospitals Trust in Gloucestershire. And at the time I came into post, into my first ICS role, I was really struck by the challenges of essentially moving patient information across the system. So I think the most important thing for me in terms of patient flow, and this is really what feeds into kind of our journey so far, is that information precedes the patient at every point in their flow journey. So at any point in time, all of the examples that I gave, there is some information, whether it be from the patient themselves, or whether it be from a clinician to another clinician, or from a hospital to a hospital, or a hospital to a social care provider. Before the patient can take the next step on their journey, their information needs to go first. So whether that's their referral, what they're waiting for, do they need a social care package, do they need a community hospital bed? And when I first came into post, essentially, most of this information was being exchanged through multiple meetings, through what I would call workarounds, which don't always observe kind of data safety in the way they should, but it's clinical and operational colleagues wanting to do the best that they can for patients, but ultimately not having one version of the truth in one place. And that will be the other key side of it, is that one person's data and their interpretation of it and another service's data and their interpretation of it can be quite different. And so everyone owning the same set of information, the same issue and the same problem and the same conversation across the system has been a real enabler in tackling some of our more complicated issues, which are those patients that have a longer length of stay and are perhaps needing to have contact with multiple services to get them out of hospital.
Thanks. And Ellen, coming to you, as Director of Strategy and Transformation, I mean, how was this challenge kind of bubbling up at the sort of strategic level across, what were you seeing that made you kind of realise that you needed to give this some attention?
So I was to say that's a really big question. I think the pressures are not unique to us. So we're seeing this across the whole of the NHS. I think there are some key metrics that we use to measure the impact of not having system flow, be that through pressure at the front door with ambulance handover delay or ED performance, through measures like no criteria to reside, which is particularly of late got a lot of political attention as well, the kind of in the old currency delayed discharges. And so like many systems, we could see those pressures mounting across our whole system. And but behind that, you've got many individual stories of people who are not getting the quality of care to which we would aspire. And that's something we really feel very acutely in our system, that for every statistic on a no criteria to reside list or a person who doesn't get an ambulance attending them in a timely way, that's an individual patient who's having a care quality in their journey that we would not aspire to for ourselves or our families. And so we want to see whole system improvement. This is just one part of our whole system improvement effort, but it's very hard to improve what you can't measure and what you can't see. So this felt like a really basic ingredient in our improvement cake, to use that analogy, to be able to actually see and understand across that whole system flow journey, so that we could then start to assess where are the blocks. And until you know that, it's hard to then go about fixing them. And I think one thing that I've really seen at the level that I sit that has come out of this is a granularity of understanding that we didn't have before, because some of those metrics that I referred to at the beginning, those sort of high level metrics, they don't tell you an awful lot. So take no criteria to reside, for example. That captures in one number a myriad of different reasons for why people experience delay. So, I mean, I don't find it a terribly useful metric actually, because it does kind of cover so many different reasons within one kind of quite unsophisticated number that you can't do an awful lot with. So what has been a real step forward in the work that Eve and digital colleagues have done and what they've achieved is when we talk about it now, we have that granularity of understanding and we can actually start to talk about the problems we're trying to fix. So, for example, we were talking the other day about a small group of people who are our longest waiters, and we're able to say, well, 3 of those are housing delays and 3 of those are, this sort of issue, and maybe 10 of them are pathway 2. We can move on to really understanding the detail of the problem we're trying to solve. And we did not have that understanding prior to all the good work to bring this dashboard together. And that kind of real-time visibility is also really, really important.
Really helpful, and I can instantly see the kind of the value that you're talking about there. I mean, Paul, to come to you, like practically, to bring all this together, tell us about that journey and what that looked like.
I think I would say it's not a single step. I think we had good foundations. So I think as an ICB, we're the same shape and size as we were during our CCG. So we've got longitudinal relationships. We haven't had as much reshuffle as perhaps some other systems. We've got we were one of the first systems to have a shared care record. So we've got a long history of doing information governance across a whole system. We have a county-wide information governance group. We have a county-wide data sharing group and things like that. So those sort of foundations that we built with our shared care record meant that actually when we then wanted to build a dashboard for Flow, those people already knew each other. They had relationships with each other. It was the trust was already there on a human level, which allowed, I think, some of the conversations to happen more easily. And then the practical level, the how to do it, there's probably multiple different ways of doing it. We reached out to the Acute Trust. They had both the skills and the capacity, and they had the platforms, the tools, the licenses in place to be able to build this and host it. And so it was something that was very much done in-house as an NHS project. We didn't need external consultancies. We had it already within the family, and so that actually meant it probably moved quite fast, really.
I'm really interested in unpacking that a bit further. So presumably you had various integration, interoperability, data alignment challenges, but you were able to respond to those needs kind of more quickly and better, having had that in-house capability.
I think a combination of having had that in-house capability, but also having had those conversations 6-7 years ago when we were building our shared care record, which was obviously for direct care. But that started those conversations, started to get sort of analysts across the different parts of the ICS talking to each other, looking at the way data came out from the Acute Trust, comparing that to data from primary care, comparing that to data from the Community Trust. So it wasn't a new conversation to us. We had a bit of a head start in that regard. It's still tricky, and you still get data in different ways from the different clinical systems, but we're familiar with it. And so actually being able to then find that common understanding of actually who's got how many people in what beds and where they are, and to then give even colleagues a system-wide view is something that was easier than I think it would have been if we hadn't done the work previously in terms of comparing, what we each have in our own baskets.
Eve, you looked like you wanted to come in on the data question. What have your reflections been on doing that kind of data join up piece?
As the operational kind of clinical person here, I think I've learnt a huge amount doing this project. I think going to all of the points that Paul's made, I think when I sort of first reached out to system BI leads, what was really great is that they all did know who each other were and they were able to signpost me. I think possibly what took some time for kind of this project, very much specifically thinking about it in terms of UEC and system flow, was getting all of the data and the BI leads together with clinical and operational leads on a regular basis. So in terms of people embarking on this type of project, establishing those relationships really early, but it needs to be both digital, clinical and operational leads working together. You need the clinical and the operational interpretation of the data, which is part of what Ellen's described, in that some of the numbers we see, there's many different ways to unpack those and understand them. But in order to build something that is clinically and operationally relevant and actually does what we need it to do on the shop floor, but then has the right data source, has the right data quality, has got the right feeds into it, is very difficult. And I think, I suppose my reflections would be, it's the sort of project that you can only really go as fast as your slowest follower if you really want to do it as an integrated care system. All of our system partners use different systems. We've got Sunrise EPR, we've got System 1, we've got Liquid Logic in adult social care. Some of the firewall issues between health and social care are interesting in terms of access, which is the very simplistic day-to-day things that then cause operational colleagues a problem if you can't access it because there's been an update into social care servers or into health servers. But I think most encouragingly for me out of this, and it's possibly not necessarily related to system flow, although we've made huge gains in kind of reduction of long length of stay and our overall visibility, are the conversations within other system partners that have been driven around kind of their own digital systems and maturity. We've been really, really supported by social care and their ambition to kind of improve their own data quality and to establish their own version of the truth through Liquid Logic has then fed in to the dashboard, but it's also moved them away from using a very kind of Excel-based system of holding patient information. So from my point of view, the whole project has unearthed so many different sorts of conversations and has engineered so many different ideas, aside from UEC and system flow, around how we need to work more collaboratively together in a kind of digital space, but also the realities of actually trying to do things as an ICS, which is that one partner, as Paul said, we were very well supported by GHFT in starting the project. They had the capability, the capacity, the leadership support to want to drive it forward. But if we hadn't continued to engage with our community partners and our social care partners, it would have gone off in a very different direction. And that has taken some time and some tenacity and some resilience of everybody who's been involved in the project to kind of realise that through.
I really like that, what I'm hearing there. You describe that combination of being really focused on outcomes and having that multidisciplinary cross-agency approach is enabling people to really have a stake and and come together around a common problem. And Ellen, from your perspective, what difference has this made? What have been the big differences, both at kind of on an individual sort of patient level and a strategic level? What are the kind of the good news stories, if you like, that you might talk about?
I think it's sort of what I started to say previously, but I would happily extrapolate on, which is that ability to really understand what are the issues driving your position, which I think we didn't have that granularity of understanding before. I think we knew in more general terms, but I don't believe that we did have that. So it helps to cut straight to solutions more quickly. So I think it helps us focus on the things that we need to unblock for our patients. And we've seen, I think we were the most improved ICB nationally in terms of our NCTR performance. That's not to say we don't believe we've still got significant improvement to achieve. We do believe that, but we have halved our figures from this time last year. So I think the proof is sort of in the pudding there, although of course the data is just the start of that. It's all the actions that you take after there have been key. But I think also in terms of our more strategic conversations, we do have that more granular understanding of the myriad of different issues that we're trying to solve as well in terms of our improvement work and bringing different partners on board. Because obviously the solution you might need to solve strategic housing delay is very different to the solution you might need to solve throughput to community hospitals or improvement in hospital processes. So I think we've been able to break that down and understand it with a lot more clarity, and therefore work on solutions that are addressing the problems that we actually have. And I'm not sure we were able to do that so effectively in the past. I think what I've also seen is Eva's continuing to progress the ask around more data coming in, so greater visibility across different aspects of our system that we haven't had the visibility about before. So we're very keen, for example, for beds in the community to have that same level of visibility, so that we can manage them in the same effective way. And that's something we can add on and continue to build. I think having this solution that was built in our system has given us really good flexibility to continue to add in different data streams as we've moved forward. So that's been helpful.
We've worked with a number of integrated care boards sort of around the country, and one of my reflections is that in some of the different agendas, including the digital agenda, the board itself is sort of struggling to find its most effective role in driving some of those changes. But it sounds like here the ICB has been really clear on how it can add that value and how it can drive something like this forward. Can you talk a bit more about the role of the board in achieving some of these outcomes?
Well, I mean, Integrated Care Board is an interesting one because it is both a board and an organisation. It's slightly odd to call an organisation a board, isn't it? So, but I think that it's really clear that ICBs do have a key role as leaders of system change, improvement, transformation. We can occupy a neutral place of kind of brokerage, and I don't mean brokerage in the sense of social care brokerage. I mean kind of relationship brokerage. So we can bring people together, we can be conveners, we can always represent the voice of the patient. I think that's something we try to do in our role around putting the patient at the heart of what we do. We have the ability to, as I say, bring together the different parts of our system to facilitate improvement across the whole patient pathway. And I'm not sure if the ICB doesn't take that role, I'm not sure who is able to take that role, because we do have that unique position of that responsibility from primary care through admission services. We hold the contracts with 111, with out of hours. We, through that hospital front door, through working with the ambulance trust, the hospitals, all the way through then social care, through our partnership in the ICB as well. So I think we uniquely hold that responsibility for the entirety of the patient journey, and thinking about the different roles of all the providers within that. So I think I've heard some reflections as well, similarly from ICBs about, this is a new world. These relationships take time to bed down, don't they? And one of the features of organisational change is that you often disrupt relationships and you have to rebuild them. We've had quite a lot of continuity in Gloucestershire, unlike some other systems. And I think that brings a benefit if we do have long-standing relationships. But I think the role of ICBs is really clear, actually, because we do occupy a unique position and we do have that clear responsibility to put the patient at the heart of the journey and to think about how all those different constituent parts can work effectively together to deliver that seamless experience that the patient would like to receive. And of course, we're probably far from that in lots of cases at the moment, but our aspiration is to continue to improve that incrementally as we move forward. And I think we've got lots of evidence that we are doing that. And it's big and it's complex, but we can see the progress starting to happen now, which is pleasing to see.
I hope this isn't asking you to dish the dirt too much, but what were the real tensions that came up where where the ICB really did play that key kind of independent brokerage role?
I don't think it is dishing the dirt, because actually we have been really transparent. And when we first started on this improvement journey, one of the things that we did was we commissioned a review working with the Local Government Association. So we did a peer review where we looked at partnership working across our system, warts and all, and we shared that in the public domain as well, including with our stakeholders like a health overview and scrutiny committee, because we felt it was important to be open and transparent about the journey that we needed to go on and what the starting point was. And it did say what I've said to you already. So it said that sometimes the patient was not at the heart of our decision making or the way that we work together as a system, and organisational self-interest did sometimes come ahead of the best interest of the patient. And our staff told us that. And we interviewed probably over 150 operational and clinical colleagues working across health and social care. And then we owned the messages that came out of that. And I think it is important to both understand your starting point if you're going to improve, and to be open about the findings of that, seeing as we are a public accountable organisation. So that is not something that we shied away from. We said, right, okay, that's what we're hearing. How do we move forward from that point? And we've tried to keep that dialogue going with people across our system, involving them in the transformation work. Ultimately, when you talk about health and social care, people who are involved in parts of the urgent emergency care journey for our patients, that's thousands of staff. So we wouldn't claim to say we communicate effectively with all of them all of the time, but we do increasingly. We're trying to think about how do we keep the comms live? How do we keep talking to our staff, sharing the improvement work that we're doing? We've got some dedicated communications resource now working just on our improvement programme. So I need to develop some web resources and sharing things through regular staff bulletins across all our different organisations. And I think that is sometimes an overlooked but really important part of transformation programmes that you're trying to run when you're trying to run at scale.
I couldn't agree more with that. Precisely right. Turning to you, Paul, I mean, and thinking about this from a clinical perspective and the clinical workforce, what did engagement look like from a clinical perspective? And what was the reaction to, presumably once the data, once there's more visibility of data, that actually has implications for, pinch points, bottlenecks, performance. Like, how did that play out amongst the clinical workforce? What's that engagement look like?
There's an interesting virtuous circle, isn't it? That actually, once clinicians realise that their notes or their data is not just for their own consumption, it drives improvements in quality, consistency, use of the recording tools, then being able to sort of see each other's data, then sort of drives that further, doesn't it? So, in terms of the reactions on the ground to the work there, Eve's probably better placed to talk about that. But certainly we know that when we've done this work before about sharing, mental health data with acute physicians or sharing, social care data, there's something about a reluctance at first, and is my data clean enough? Is it good enough? Am I proud of it? Then there's something about actually that gets to a point where it actually is something that you'll stand behind. It also, interestingly, sometimes opens up miscommunications, that the NHS is littered with acronyms, and the same three letters mean different things to a social worker, to a GP, to a surgeon. So you have to be careful about assumptions around that and the way that we count things. Are we still counting, apples and oranges correctly, or have we got crossed wires? My experience as a clinician, and showing data to clinicians is that we're incredibly competitive. We're incredibly proud of delivering the best quality work. So show a clinician something that says they're in the bottom 2/3 of the pack, and the next quarter they'll have moved, and it's incredibly powerful if they believe the data. So the one hesitance I would say about that is you've got to do the work first so that they actually believe the data. Otherwise, they just try and pick holes in it, and you actually end up having the wrong conversation.
Eve, did you want to add anything to that?
Only to say I completely agree with Paul. I think part of what's been useful about this information is reflecting each partner's data back to both themselves, but also to each other's. But obviously, you need a really kind of safe cultural space to do that in. So it's about working to the problem and keeping the patient at the heart of it. every review of every metric leads to an action. So it's really, so if I'm honest, the system flow dashboard for me is the face of a huge amount of work that happens underneath it, that is driven by, has there been a rise in this, or is there a longer wait for social care packages at the moment? And that drives a different set of conversations across the system. I think, to go to Paul's point, when we first started the build work, we deliberately only allowed access to the dashboard to a very small group of people who were all experts in their field. They're all system flow leads, and we worked with the data. So absolutely, to Paul's point, we spent a lot of time optimising the data, making sure that the data was right, making sure that everyone was happy with it. So operational colleagues were happy with what was being fed through from digital colleagues, to create the safety and the trust that you need to. Certainly when you're exposing some of the figures that, as Ellen's referred to, we're all, under quite a lot of pressure to deliver improvements against. So, to do that together as a system, there are always points in UEC and Flow whereby maintaining those relationships across organisational boundaries, so that providers don't become protective of what they perceive to be their own metrics, if that makes sense. Because ultimately, if you do get into that space, you're essentially working in a siloed way, but from a clinical and operational point of view, so doors are closed rather than opened. And in order to make a patient's pathway flow really smoothly, you need all of your doors to be open at the right time. But if you don't have the right relationships built between partners on a really operational, clinical level, you won't. But also similarly to what Ellen's described as a board level. So for me, in my role, sort of having the data and the information and the contact that I do to it has enabled me to report, I think, more effectively to executives and to board directors in terms of understanding the problem. So I'm not presenting a set of numbers that mean a really difficult position. I'm able to say, this is the issue, but this is potentially what we need to do to solve it. And often what we need to do to solve it isn't actually in the provider where the issue is. And that's the key thing. The delay might be in a hospital, but actually the issue we need to think about is housing or complex social care, or how do we get more people home first. So it's a lot more complicated than just looking at kind of individual metrics across providers, but you get the system view.
Absolutely. I mean, it's incredibly impressive, really. Like, how do you have any tips? So for that situation where you identify that a problem that one organisation experiences is due to a bottleneck in another, how do you win that argument around, persuading another organisation to do that investment where the benefits might not be realised there, but it's kind of for the system whole? Are there any tips that you have around having that discussion or forming those relationships in kind of practical terms?
I can probably answer from an operational point of view, and I'm sure Ellen would probably want to comment more from a board position. For me in my role, I think it's really, really important so I spend time in all of our providers in our system. So I work really closely with GHFT and GHC and our social care providers. I think part of my role and how the role's developed, we've seen some slightly different governance architecture come together in our system. So we do have a weekly system-wide escalation group at a tactical level and at an executive level, which brings together our cross-system sort of chief operating officers and chief execs, but that's on a weekly basis. That's largely reflective of the pressure in system flow, but it does enable, I suppose, me in my role to platform that discussion in a really careful way. And you do have to manage the conversations really carefully and really sensitively, and acknowledge that everybody in their organisation is trying to do their very best, but that ultimately potentially taking a hit, for want of a better word, in one place, we can get a greater gain in terms of the patient outcome. A classic for me in that is the dichotomy between wanting to buy more beds, which is often what the push is. It's not necessarily the right thing for patient outcomes to buy beds. I think one of my colleagues frequently says the only place we have enough beds is in people's homes. So how do we get patients home with the right support? But that does require that interchange between health and social care. So where is that pressure going to be felt? And some of that does come down to financial pressure as well as operational pressure. So it is a difficult conversation to manage.
Ellen, did you want to build on that?
Yes, I mean, I think Eve's given a good description, but I think relationships is all. So you cannot overinvest in relationships, in time, in being present for people, and even in this virtual world, being face to face is really important. I'm talking to you now from camping out at the Hospitals Trust, so I regularly make time to come and sit and base myself here. And we had a really difficult day yesterday on system flow. One of my important jobs this afternoon is to take the Chief Operating Officer here at the hospital for a coffee and a debrief, because it's really difficult. These roles are really hard, and we have to have empathy for each other and keep trying to remember the kind of human side of what we're trying to do. And on the same vein, I would say and I know people talk about this quite a lot, but it is the key of why we are here, is to keep coming back to the patient story in the middle. And, we had a difficult situation the last couple of weeks with some patients who'd ended up with very long stays. Eve circulated that the stories pseudonymised. Again, we asked senior leaders to look at those, and we're reminding people this is not the journey that we want our patients to have. So I know these things are difficult, but let's get back around them. Let's look at how we can improve. We've got some very difficult cases here, a small number, 10 people, for example, but let's look at that and let's take the learning again. We have to keep coming back around that loop, but also remembering this is about a group of people coming together in work to try to do the right thing, and that we have to keep working together to solve these problems. And I think a kind of combative stance, it doesn't work. So it is about that. And Eve's put a lot of time into, again, building space for people to work together. We have what we've called Flow Friday. It's a sort of open space type event. Once a month, people come, operational leads, they work together. You've got health, social care, but also everyone's invited. So it's not a kind of, oh, well, you're invited to this session, you're not. If you want to be part of it and you think it's helpful for you to be there, then you're welcome. So I think, and the same with the clinical programme group network that we've set up, we invite everybody to that to work on solutions together. And that includes like our private providers who provide one-on-one and out of hours and so on. They're all welcome. And we all talk about how we can improve together around the patient journey. And when we had our winter planning event, I think, correct me if I'm wrong, Eve, but we had like over 100 people who came to that. And again, lots of representation, social workers, clinicians, operational managers, directors, but all working together, and importantly with some lunch and a bit of open space time as well. Because often, and I think again what's also important to remember is this is not complicated stuff, but often we're asking people to go over and above and make discretionary effort. And in my view it's quite simple. You're more likely to make discretionary effort for someone you like and respect than from somebody who you don't. So relationships are fundamental to us every day, asking this discretionary effort of our teams and our colleagues to deliver services in what is possibly one of the most difficult border scale contexts that I've ever worked in myself in the NHS in quite a long career. Financially, post-COVID, politically, cost of living crisis on people, all of these things make this a very difficult and challenging environment to work in. This is tough times, and we are asking a lot of our teams to come to work every day and deliver in this context.
Thanks, Ellen. And that combination I thought was really, that you talked about actually putting the individual patient stories alongside the data, so you've got the kind of qualitative and the quantitative to tell the whole story, I think is strong approach. And the aspects of working in the open and the transparency also felt like obviously that must be really important to build trust across the system as well. So we're running out of time, so I'm going to come to my last question, and I'd like you each to have a go at this, and we'll go in the order of Paul, Eve, and Ellen. And my final question is: let's pretend I'm a system leader somewhere. I know I've got real problems with flow, but I've got no visibility of where those problems are, and kind of just a bit stuck, flying blind. Where do I start? Like, what's the most important thing for me to do next to start to solve this problem? How do I start to address it? And we'll go to you first, Paul.
So, I think slightly ironically, as supposed to be the digital lead for the ICB, I would start in a very analog place. I would say get people together, get them in a room, get them to meet each other. Anna was saying about, discretionary effort. It's people it's people you trust, and it's very hard to build trust remotely. So I think you could workshop quite a lot to get people together, bring in their various different laptops from their various different organisations. You could start throwing numbers together fairly quickly, and you could probably achieve quite a lot in a half day or a day in person, rather than trying to stand up more meetings and this, we're meeting today, aren't we, virtually, and it works and it's got a place. But certainly if you're starting and you want to get things moving, I don't think you can beat bringing people together.
Thank you. Eve?
Yeah, similarly to Paul, I would say certainly for me in my role, find your people, and those people aren't always the people with the job title that goes with what is expected. So there are a core group of people that I could name really easily that have been involved in this project from the get-go, from across digital and BI and operational leads. Some are quite senior, some are quite junior, but they all are experts in their field. They understand their data, they understand the problem, and they have an ambition to realise the vision of the project. And I think that's key. It does take quite a lot of personal resilience and kind of, to work alongside colleagues ongoing to realise the benefits of this type of work. So I think for me, it's find your people, but equally as much for me as an operational and a nurse by background would be to say, find the people in your digital worlds that are going to help and support and want to really, because we would not have been able to realise this without the collaboration with our digital leaders across the system at all.
Thank you. And to Ellen?
Yeah, I agree with what Eve and Paul have said, and it's all coming down to the people, isn't it, and that discretionary effort again. I think the sort of third plank there probably then is just the recurring theme that we said about putting the patient at the heart. So we did a series of case reviews where we looked at about 100 and something patient journeys with teams together in real life in rooms to sort of advocate from the patient's point of view and do that walkthrough. And that wasn't directly linked to this project, but what I think that really helps you to do was alongside this. And if someone was starting from fresh, this would be quite a good early thing to do, as it helps you start to appreciate the blocks in your system and therefore why it is imperative for you to work together in order to address those. Because we also revealed through that process that people don't often have a really good understanding of what different parts of the system do. And that's often where blocks can come, because the NHS and social care system is big and complex. And if you're a nurse working in a ward, you probably don't know all the services that exist in the community. And that's not a failing on your part. It's just you're not exposed to them on a sort of daily basis. And some of what drives those issues for our patients is that lack of understanding about what's available at all different parts of the journey, and how to access them and how to navigate them and all of those sorts of things. And so when we start to understand that, we can start to see the value that sharing information, sharing data, working together on integrated systems can give us. And so that helps people to really want this rather than feel like it's something they're being told to do, which I think, and it being open access and used by appropriately with people with the right permissions and so on. It's used by the teams across. It's not just used by the ICB. It's not something we just hold to ourselves. So I think that's really important as well. So that's the kind of platform and the mandate for change, if you like.
Extremely compelling. Thank you very much, all of you. So, today we've set out a really strong case for the value in working this way. I was really struck by, if you can't see what's happening, then how on earth are you supposed to be able to unblock the problems? But starting in a lo-fi analog way to build that trust and start to explore the art of the possible really resonated with me as well. Empowering expert multidisciplinary teams, but keeping that vision in place that has the patient at the centre, and driving towards an outcome that everyone can share the benefits of, is fantastic achievement to have got there. So well done to all of you. Really appreciate you joining the discussion today, and good luck with winter.